Dr. Jarvis. I work at the Jewish General Hospital, and I work with Lawrence, and I'll give you different examples of how culture changes by setting in professional, especially professional settings. I want to talk a bit about definitions, or I'll give you an outline first. This is what we'll cover today, generally speaking. So here's the outline. So it's definitions, background. We'll do these country comparisons, psychiatry in different countries and how they treat different aspects of psychosis, especially among immigrant and migrant groups. And then we'll see if we have time for clinical implications. The global implications are shorter to review, but the clinic can get longer with several vignettes if we have time. We'll just see. Good stuff. So just a few definitions first of all. It should be old hat to you now in the Culture and Psychiatry class. Culture being like all of the acquired traditions and wisdom from society passed down through generations, attitudes, expectations. This is what we believe to be culture. And in this class today, we won't be talking about so much culture in other places, as may have been done in former decades, but looking more at this kind of notion of culture from Lawrence Kiermaier. Something that talks more about cultures of biomedicine and psychiatry. Maybe Alan Young was talking about it already in great detail, yeah. So we'll kind of spring off from his words maybe into areas of psychosis, which is my area of specialty within psychiatry, is psychosis. So just for background purposes, are all of you comfortable with the idea of psychosis? You're probably mostly mental health professionals. These are the broad categories of psychosis that exist, at least according to DSM-4, to the International Classification of Disease. So this is psychoses, the typical symptoms, hallucinations, delusions, paranoia, disorganized behavior, and thinking. So I'll give you some background to this approach, which sort of influenced my vision of how to compare the psychosis by setting, by psychiatric culture and setting. So back in the 50s, C.P. Snow wrote a book called The Two Cultures. You might be aware of this. It's kind of a classic now. And he sort of divided the intellectual world into the sciences and the humanities, and said there were two different cultures, and they saw things very differently, fundamentally differently. And more recently, Jerome Kagan, you may know this book as well, he kind of went forward from what C.P. Snow wrote. Jerome Kagan inserted the social sciences into the no man's land, or into that empty space. And so Jerome Kagan analyzes these three cultures, intellectual cultures, by different dimensions. And we'll look at just four of them very briefly, just to give you a taste of what they're talking about and how you could look at these ideas in comparison. So he puts across the top natural scientists, social scientists, humanists, and then these dimensions here, you can look at something such as primary vocabulary or influence of history. So going to the bottom, the influence of history in these three cultures, you might have, he says, at least in his book, natural scientists tend to look at history minimally. It may not influence their thinking heavily. This is what he's suggesting. Social scientists may be somewhere in between, and then the humanities or humanist history has a major impact on how they understand the world, the culture of the humanities, the culture of humanism. And you can look, it's a very interesting read. There's 9 different dimensions. I just put a few down here just for your benefit, your interest. And so the same kind of approach could be applied to psychiatry. And the first time this ever happened, as far as I can tell, it may have happened other places, be free to let me know if you know more than I do about a certain area. I certainly wouldn't claim to know all that there is in these areas, but I haven't found a lot. But back in the late 60s, early 70s, with the US-UK Diagnostic Project, there was a comparison of how schizophrenia was diagnosed and assessed in London and in New York City. And the authors of the study found some very interesting differences. So they found that, well, it was not very favorable to the New York psychiatrists, to the American psychiatrists, because the London psychiatrists felt they way overdiagnosed schizophrenia, and that their diagnostic criteria were too over-inclusive and included many other diagnoses that the British psychiatrists would have cut off and put into other areas. So this kind of awakened a self-reflection in North America. And I think the American psychiatry in general was a little bit jarred into action. And so they began to come out with very research criteria-based diagnostic systems, okay? And DSM is one of those. So DSM kind of picked up after that and became a lot more structured. And schizophrenia, along with many other diagnoses, became organized in this way. And you can go back into the historical chronology and see these things kind of flourishing after this study in the late 60s. It was published, I think, in 1972. So this is an early comparison of psychiatric cultures. Usually what we do is we're looking at patients, clients, individuals, families, societies, and trying to find out what's working within them. But this is taking the perspective more of the observers, you know, and what's happening from their perspective, which I find personally very more interesting in many ways and more rewarding, although both are necessary for sure. So what we'll do is we'll look at these country comparisons on three different, I guess, dimensions. One would be attributed etiology of psychosis. One would be the treatment variation by ethno-racial category, of psychosis. And the last would be reported rates of minorities. Reported rates of psychosis, that is. Let's look at attributed etiology. Any questions about the background so far, what we're trying to do, or how to compare why we would be looking at this kind of question? Because sometimes what people get worried about in this class and other places is they go, well, what's the real answer, you know? Like, what are the rates of psychosis here or there? What are the real treatments we should be using? And here in this class, or what is the etiology of psychosis? Where does it come from? Now, I'm not here to deliberate the fine points and to come up with an answer. I'm looking more at what different places have said about these questions. Okay, so you know, if you have questions, feel free to ask. It's not a problem. I just have to kind of say that at the beginning, because some people get worried that I'm saying something's wrong or right when I'm not really saying anything about that. I'm being filmed, right? Yeah, okay. I'm not saying anything at all about it. I'm just trying to show what's being said, okay? So default position of psychiatry. So this is looking at sort of the etiology of psychosis. This is a proposed default position in psychiatry that psychosis, or especially schizophrenia, is a neurobiological disorder. It has neurological origins or brain origins, okay? Now there are doubts, obviously, looking at, well, for some anyway, there may be doubts about a biologic or neurological origin of psychosis. I'll just run over a few here for you. Just for your information, before 1800, this neurologic disorder, sort of well understood as being neurobiological in origin, cannot be found reliably in the world literature. So it seems to have come into being after 1800. And not so for melancholic depression or anxiety states or PTSD or many other kinds of problems, and it could be addressed by psychology or psychiatry. But schizophrenia, strangely, is, if not non-existent, extremely rare and doubtful to diagnose from historical case examples. And there seems to be kind of a flourishing of schizophrenia with the onset of industrialization after 1800. So this is one doubt about the biologic moorings of psychiatry in human beings, really. Now, the findings of the US-UK Diagnostic Project, I just mentioned some of them, a very brief summary of them to you, raises doubts as well about the neurological, biological origins of schizophrenia, just because the diagnosis can vary so widely given setting. At least it could back in the 70s. We'll look at that again more later. You may know about high rates of reported psychosis and schizophrenia in immigrants to Western Europe. I don't know if you've heard of this finding before, but this is in psychiatry. It's a major finding, and it's a more relatively recent finding. So high, very, very elevated rates in certain ethnocultural communities, say in London, Amsterdam, maybe in Stockholm. So why would there be funny aberrations in rates of disorder clustering around certain immigrant or ethnic groups? Also historically in the United States, rates of psychosis attributed to African Americans has changed over time. So in the pre-Civil War era, the rates of psychosis among slaves is thought to be non-existent. But then after the Civil War and after emancipation, the rates of psychosis in the emancipated former slaves skyrocketed and climbed for the next century. And then after the Civil Rights Movement, high rates of psychosis in African Americans disappears again from the American literature. And we'll discuss this more later. So now that's not the finding that's being reported in the American psychiatric institution anyway, or in the American psychiatric journals. These cast doubt on the idea that there's sort of a persistent neurologic basis for schizophrenia psychosis. There probably still is. There is in many cases. But I'm just saying these cast doubt on that notion. Now, equally, in the recent European literature, there's been a burgeoning authorship of articles having to do with social risk factors for psychosis. And these are just some. I apologize for the smallness of the writing. I can barely read it on my screen here. But I'll just run through a few of them. Social disadvantage, discrimination, such as racial discrimination, low ethnic density. I don't know if you know what that means. It refers to a certain population, a minority population, having a relatively small presence in the larger society. A high ethnic density means there's a larger number of that group present, larger proportion. So low ethnic density has been linked with onset or rates of psychosis. Unemployment, childhood trauma, migration, first or second generation. We just talked about migration a little bit. Visible ethnic minority in general, being a visible ethnic minority, meaning what would be called non-white in the United States, say African American, Asian American. Okay, general neighborhood effects, social isolation. Most of this work comes out of Western Europe. A little may come out of North America or elsewhere, but we'll talk about this difference later. Why Western Europe has become more focused on social risk factors for psychosis as opposed to biologic. And it's linked heavily with the immigrant issues, with high rates of psychosis in immigrant populations to Western Europe. I'll just present to you some ideas from a recent study about looking at the attribution of the etiology of psychosis in 3 national psychiatric journals. So we're going to talk about how different psychiatric institutions or psychiatric cultures, or at least how different national psychiatric journals may consider the role of social etiology of psychosis. So here's the hypothesis. A greater proportion of articles in the American Journal of Psychiatry will attribute biological factors to the etiology of psychosis, while the British Journal of Psychiatry will attribute psychosocial factors more commonly, and the Canadian Journal will follow somewhere in between. We always fall in between, right? The United States and the UK, we're just caught in this world. We can't escape. We're in between these giants. And you have to throw France in too. We'll bring France in later. That completes the picture. Okay, so the methods of this comparison was a Medline search for articles from these 3 journals between 2005 and 2007. 360 abstracts were found with psychosis and etiology in the abstract or title. That's how we kind of gathered our subjects, which were non-living subjects. But there may be indicators of the culture of a certain group, since how many people really read articles in a journal? I don't know, but it's not often. Usually you might just peruse a title or an abstract, kind of get an idea of something. Maybe you'll go deeper into a few. So that was kind of our reason for working this way, was to gather sort of what people might notice quickly on kind of a quick skimming of the literature on a topic. So raters were blind to journal of origin and determined whether causality was implied, reducing 149 relevant abstracts. And let's see, what did we do for this? A chi-square analysis was used to see if there were differences in attributed etiology and proportions of attributed etiology. I don't know if you know about that kind of, I don't mean to get too much into methods. These are simple methods, really. What happened basically is we found that the British Journal of Psychiatry had a significantly higher proportion of articles that attributed social etiology of psychosis than the American. The American Journal of Psychiatry had almost none at all. Almost none. We were worried it wouldn't have any. And it would be hard for us to do comparisons, but luckily there were a couple. And the Canadian Journal, there were too few in number to do a real comparison, but the pattern of the results were similar to the British. So with respect to the etiology of psychosis, as I mentioned, the AJP publishes an overwhelming majority of articles with attributed biologic origins, only 6% with an attributed psychosocial origin. But the British Journal of Psychiatry was much higher, 36%, still a minority of articles. I mean, we live in the age of the brain and biological psychiatry, biomedicine. We can't escape, right? Just like Canada in between the United States and Canada, we can't escape biomedicine entirely. But more than a third of the articles that we found in the British Journal of Psychiatry looked at social causes of psychosis, which is interesting. What we hypothesized is that maybe because of the focus on immigrants and immigration and the link between migration and psychosis in the minority populations of Western Europe, maybe this is changing the way that psychosis etiology is being discussed, even in major journals like the British Journal of Psychiatry. We haven't looked at other journals from Western Europe, but I don't know, it could exist there as well. But in the United States, where this discussion has not permeated at all, there's no discussion of immigration, psychosis among immigrants to the United States, nothing that I've found since the 1970s. If you hear of anything, if you know of something different, let me know. Because of that, we felt that biology remains unchallenged as the predominant explanatory model for etiology of psychosis in the United States and in the psychiatric institutions there. We'll look at this a little bit differently. Let's see, final position, the etiology of psychosis, the attributed etiology of psychosis is mixed, depending on the setting. It can be more or less social or biological, depending on what place you're looking, what journal you're looking at, what psychiatric culture you're examining. So are there any questions about this first kind of example of how to do this comparison by setting? Oh, we're just preparing the manuscript. It hasn't been published, yeah. We presented it at a symposium, and there was some interesting feedback. I don't know if people really understood it because, again, people are looking for the real etiology all the time. Like, well, what is the etiology? Is it social or biological? And that's not really the question we're looking at. We're trying just to see who's reporting what here and there, you know? So yeah, I'll let you know later. Yeah, we probably will try to publish, I think we'll be more favorable in Europe than in North America, since we kind of portray them as being sort of cutting edge, you know, not sort of stodgy and back in the biologic world, which isn't always bad, but yeah. Oh, yeah. We should look at that actually, that's a good question. That's a very good question. I don't know. I'm not even sure if we looked at that information. We have a page on the sources and what institution, who the authors were, what gender of the author, and so on. But we haven't really analyzed that data. And I have to look back and see if we looked at if it was drug funded. That's a very interesting question. It's a good question because the American Journal of Psychiatry is quite international, really. There are a lot of contributing authors from different places. So we do have information on the submitting institution of the author, because we don't really know who the authors are. I mean, it will say a name of somebody, and they're linked to an institution somewhere. So we have that data, but where the authors come from, you know, I mean, it could be international people who are working in an American institution. So how do we interpret that? But that's a very interesting point too. There are grave limitations with this study. I mean, I don't mean to say that it's something that is certainly beyond question or doubt. And we'll see how we can get this published. We have to finish writing the paper first, which is always the big issue. So any other comments on that issue? Or it's more just an illustration, though, of what you can do, what kinds of work you can do. Not even to say this is a fantastic piece of work on its own. It's just to show that you can do these comparisons and find results, which is interesting. And it's nice in a way. The subjects are easy to find. They're on Medline, you know, you don't have to sort of get informed consent and stuff. So, all right. Thank you. Well, let's look at a different example. Treatment variation, meaning treatment of psychosis, and how treatment might vary. This is the weakest of the three. It's I just haven't fleshed it out as well as I should have. But I can go through some of what I've found. We can discuss a little bit about treatment issues that I've been able to uncover. By the way, we'll look at the UK, a little bit of Canada, the US and France today, but there's other countries that are ripe for analysis. The Netherlands has a nice literature, and Israel as well, interestingly, has a literature that's coming up on some of these issues. So I'm gathering information, but they're smaller. Well, the Netherlands is quite big now, but the Israeli literature is just coming up. So the default position about treatment, I think every physician would hope that treatment of psychosis should be independent of a patient's ethno-cultural or ethno-racial background. I mean, you know, nobody's going to try to treat people differently on those things. According to WHO studies, the DOSMED, outcome of psychosis should, in theory, be better in immigrants from traditional societies. Now, I don't know if you've studied or heard about the DOSMED, the World Health Organization studies. There was a larger one, the IPSS, well, not a larger, a different one in the 70s, and then a follow-up study, which was an incident study, which captured new onset cases of psychosis in 14 sites around the world over a year period. Very ambitious study. They published their report in 1992 in a Psychological Medicine, a supplement. And what they found, basically, they found a couple things. One is that the incidence of schizophrenia, if narrowly and conservatively defined, is universally the same. Whether it's Nigeria or Colombia or India or Denmark or Hawaii, they found kind of a similar incidence if they narrowly defined the construct. The second thing was that the outcome of schizophrenia psychosis is better in developing centers, meaning more traditional societies or poorer nations than in the wealthier nations. And this has been the enduring finding of that study. Well, these both have been enduring findings which have been frequently cited in psychiatry for the last 20 to 25 years. So we're kind of coming up against this earlier work by the World Health Organization. And then the idea is, well, maybe if people with psychosis in India have a better outcome, say, maybe immigrants from India or immigrants from Africa to the UK or United States, maybe they'll have a better outcome as well, right? Like that's sort of what people thought maybe in the late 80s or early 90s when this work was getting finished. So let's just look at the UK then. And in the UK, basically there are two main findings with respect to outcome and treatment. Basically that there's more police contact among patients with psychosis, schizophrenia. More police contact among African British or Black Britons or Afro-Caribbean British, mainly immigrants, also second generation people in the country. The second finding is that there's a higher rate of Black Britons who are forcibly detained in psychiatric hospitals, okay? This is very well documented, and this is kind of the classic paper. Morgan et al., 2004, he exhaustively reviews the literature to that time, and he finds here that there's a relationship between being African Caribbean, psychosis, and being a coercive interaction, or a coercive relationship with police and with forensic facilities in the UK. Mental health, coercively detained in mental health services. Let's look at the US. The United States hasn't looked at these questions the same way. It's not so organized, okay? The United States is huge and there's different people doing different work in different parts of the United States. The UK, Western European nations are a little more compact, and so they kind of work as a team almost, and they get these sort of these studies going that are epidemiologically sound and catchment area based, and they can determine incidents. I mean, it's incredible what they do that way. The United States, people are more working independent of each other, and they come up with varied findings in varied settings. There's not so much of a national strategy or a national database, really. which in some Scandinavian countries, there are national databases you can turn to look at all these questions. It's phenomenal for research like this. So in the US, there's less written in this way. Here's some findings from the United States with respect to psychosis in African Americans. Now, a lot of this work is focused on people of African origin, which has been criticized often. Why the focus on this group? Why not other immigrants? Why not other minorities? And so there's been more in the last decade than before. So African Americans tend to stay in psychiatric treatment. Here we go. For less time, you can see this better. Receive more inpatient care, have poorer mental health outcomes, are prone to mistrust their therapists, are more likely to be prescribed old-style or depot antipsychotic medications. You know what depot medications are? They're injections, okay? So instead of getting oral medications, it's more likely for African Americans in some studies to receive injectable, long-acting forms. Why would you give that to somebody? Well, you might think they're not going to take their medication, they're somehow unreliable, okay? So this is maybe what's going on behind the scenes. African Americans with psychosis are less likely to be treated by a board-certified psychiatrist and tend to be high users of self-help agencies. So, well, given this outcome profile, it's no wonder maybe that some members of the community might be looking elsewhere for help, for psychiatric, even psych. It might be like a para-medical organization. Like say in Quebec we have AMI Quebec, which is an alliance for the mentally ill. And they might have like meetings for family members, and they advocate for mentally ill, and they may give lectures about what mental illnesses are and how to reduce your stay in the hospital, how to avoid getting picked up by the police, or this kind of thing. So this is some of the findings for African Americans with psychosis. The amount of antipsychotic medication given to African Americans or Black Britons is sort of, the findings are inconsistent, so I didn't put down a finding here. A Canadian study, this is looking at determinants of police contact of African Canadians in Montreal, at one hospital in Montreal. And you can see here, a study done a few years ago, number of psychotic symptoms is highly statistically significant predictor of police contact. So if you have many psychotic symptoms. Also, being Afro-Canadian was associated with police contact prior to admission to psychiatry. So even in Canada, I just raised that to show that it's not all about the US and the UK. Canada has something to say on occasion. So it may be that in line with professional attitudes of etiology of psychosis, British treatments of ethnic minorities vary in forms of social intervention like police contact and compulsory admission, while the American treatments tend to vary in forms of biological agents, like the type of medication and the route of medication. So I don't know if it's true or not, but there may be a link between more of a social etiology of the illness and social forms of intervention, and more of a biologic idea of the etiology and maybe biological interventions. So a final position on this example, treatment and outcome may be worse for ethnic minorities living in the UK and the US, as opposed to being better. If you're expecting large numbers of immigrants from traditional societies where outcome may be better, coming to North America or Europe, you may think, oh, they may have a relatively benign outcome. Instead, we find they get mired in these systems where they're detained more often or given long-acting depot neuroleptics or antipsychotic agents. So this is just showing how there's a change after immigration. And this is a much bigger example, reported rates of psychosis, just the rates issue. And the default position of psychiatry I mentioned already from the USMED is that there's basically schizophrenia, especially narrowly defined schizophrenia, is sort of there's a universal rate. It's biologically underpinned. It comes from neurobiology, so it's going to be everywhere there are human beings, and human beings are essentially the same everywhere. So the hypothesis is that it should kind of come up at roughly the same rates around the world in different settings and sites. And we're going to challenge that and do that by comparing rates of psychosis and how they're reported in different countries, by different psychiatric institutions in different countries. Institutions meaning the apparatus, like not one mega hospital or something. Okay, here's just a couple of counterproposals. So contrary to the WHO findings, rates of psychosis and schizophrenia, especially psychosis, which is a bigger, more broad concept than schizophrenia, are not universally similar, but they depend really on who's doing the counting and under what conditions. Okay. The differences in the reported rates of psychosis in the ethnic minorities of the UK, US, and France should not be surprising, simply because these psychiatric languages that they use are very, very, very different, and the histories of those countries are quite different. So it may not be so surprising to think that they count psychosis differently, in fact, drastically differently among their minority populations. So the pattern of analysis will look at how the rates of psychosis are reported in these three countries, and we'll look at official ethno-racial categories for the censuses of the UK, US, and France. Then we'll look at quotations, historical quotations from the public, from professional literature, and then we'll look at some historical underpinnings of how we might have gotten where we are today. The reason that I chose these three countries is A, they're major countries in the world of psychiatry, so there's a lot of publications coming out of these countries. There's not so much overlap between France and the other two, but France is a major player in the European scene, and they also have a literature that you can study. Now, other countries are smaller, or they may not have such a big English literature. And I also speak French, so I can read the French literature. So that's why I chose these three. There's no reason to choose them a priori necessarily, but they happen to have quite a different way of understanding things. So, okay. Thanks, that's a good question. So let's start with the UK, and I'll define the UK as a high rates of psychosis in minorities country, all right? This is the position of the UK. Are ethnic categories permitted in the United Kingdom? Can they study ethnic categories? Can they assign ethnic categories? Absolutely. The UK has a long, proud tradition of assigning ethnic categories to minority populations. And it began much earlier in the 19th century with the Irish and the traveling Irish. You may have heard about them. They've been in the news recently. There was a big problem in the UK recently about a traveler community that was ousted from its land. Anyway, these ethnic categories, here's the 2001 census. These are the kinds of groups that could be permitted. I just added religion on the bottom, country of birth and religion, to show you that there's other categories besides ethnicity that are permitted in the census. And then just for your benefit, I added the categories from the 2011 census. It's just coming out now, but they have some information online about it. And so it's changed a little bit. Some changes. Asian or Asian British. Oh, the Chinese, it was interesting. Chinese or other ethnic group was a separate one before, and now Chinese is in the Asian, and other ethnic group they had as examples Arab. Okay, so that's what they're going for now. So the issue of migrant studies in the UK is it's a major issue in psychiatry, especially with respect to psychosis. And these are a few of the key studies. Coit et al. Is 2008. Sorry, I didn't put the year in for that one. But it's continuing to the current day. There's a lot of interest in rates of schizophrenia and psychosis in immigrant populations to the UK. And back in the late 80s, there had been a kind of an informal literature up until the late 1980s, until Harrison used World Health Organization methods, the ones they use, the exact same, to create an incidence-based study in Bristol. So he began to, or it may have been Nottingham, I can't remember which city it was, Bristol or Nottingham. And so what he did was he found extremely elevated rates of psychosis, schizophrenia in African or black Britons living in his city, the city that he studied, and it was an incidence-based study, so it had higher credibility than the previous studies in the UK. And we're talking like maybe 13 to 14 times the national British rate. Hugely increased rates. And these two studies are very interesting to read because it started off a whole new literature. And there's been many, many repetitions, or I should say confirmatory findings since that time. And one of the biggest ones was published in 2006. It was a 3-center incidence study which found virtually the same finding, but the rates were a little bit less elevated, maybe 4 to 6 times higher among African British, and higher in other immigrant communities as well, like South Asian communities, for example. So, do you have a question? They did some of those studies, and they went to the Caribbean in particular, and they checked out like Barbados and Trinidad and other islands to see their national average of psychosis onset or incidence rates, and they found them much lower, more comparable to the general British rate. So these were higher compared to them as well, although they weren't the same study. I mean, you can't always just compare like that, but they went and did, they've sought out all kinds of different reasons for this finding. Now, this is the landmark, summary of the landmark study in 1988. It's very interesting because Harrison was hoping to find, higher rates of atypical psychoses based on the findings of the World Health Organization, and he was hoping to find a more benign course of schizophrenia in the immigrants, but he found neither. He found the same or worse outcome, and he found very high rates of narrowly defined schizophrenia. Okay, so I just sort of summarized this. And the findings persist into the next generations. So it doesn't just stop with the first arrivals. Their children continue, in many studies, continue to have the same finding. And there are critiques that come up around misdiagnosis and black schizophrenia, like what are we doing portraying a community in this way? What are the negative effects of that stigma? But these are minority, well, I shouldn't use that word, they're neglected perspectives, okay? Definitely minority perspectives. Yeah. And like, you know, one of the proponents of this, a well-respected scholar, publishes many of his articles in newspapers, because that's more where it's a frustrating thing. Okay, now there's a history to this, and I won't really have time to go through all this, but it's very interesting. 1968, there's this Rivers of Blood speech by a prominent UK politician, which essentially underlined the fear of immigrants in the United Kingdom. I mean, this is after World War II, and huge migration to Western Europe from former colonies, threatening the people that are there. It's an assault on the British identity. In fact, I have some quotations about national identity, maybe interesting. Here's what this one writer wrote about. He's summarizing information. It's not from him, this isn't his view. But he's saying here, the population sees black and brown citizens as a hindrance to the emergency of a new identity of the British people. So this is just pertaining to the United Kingdom, no other countries. Now this is kind of a quotation that's interesting from the same book, talking about how there had been a colonial past and a division between the white overlords and the people of color this is common knowledge. This is interesting. The point is not that there may not be a connection or connections between ethnicity and mental illness, but that the relationship between psychiatry and black patients has been intertwined with pseudoscience and racist ideologies from the imperial age. So you don't have to go back too far to find evidence of these ideas that are undergirding some of the practice of psychiatry and the theory of psychiatry, especially with respect to immigrants and minority populations. Now, parallel to this, in the 1960s and 70s, there arose a confidence in the accuracy of diagnosis of psychosis in the United Kingdom, so that the people they were kind of cutting edge, okay, at the time, and so they had instruments that were widely valued, I guess, by the psychiatric community. So going back to the US-UK Diagnostic Project, one of the conclusions of that comparison between London and New York City, how they diagnose psychosis, this is kind of a cutting conclusion. The New York concept of schizophrenia is not a useful one and is likely to inhibit fruitful research if it is widely adopted. So, a terrible blow to the Americans. So they began to kind of change their pattern of diagnosis after that. And in fact, they became completely enveloped in the issue of misdiagnosis. after their early 70s, and we'll talk about it in just a minute, okay? And in the United Kingdom, on the other hand, they were sort of assured that their diagnostic tools were excellent. And so they continued to use them, and it's these tools that are showing high rates in immigrant populations. But there is a forgotten caution. The present state examination is one of these instruments that's been used, and its derivatives and next generations have been used over the last 30 to 40 years in the United Kingdom in particular. But at the beginning, when it was being created, there was this interesting caution attached to it. The present state examination places considerable reliance on the interviewer's clinical judgment, both in the conduct of the interview and in decisions about the presence or absence of individual items of psychopathology. This element of freedom involves the risk, a risk which even the most comprehensive instruction manual will never eliminate, that psychiatrists with different backgrounds and orientations may differ widely in the ratings they make. So there's this caution that I think we need to take stock of when assessing the UK data over the last several decades, which I think has not been addressed properly by the field or by the British researchers. This is just a summary of historical antecedents to what we see today in the United Kingdom. I don't want to kind of belabor this, we don't have too much time. But we know there was an overseas history of slavery, colonial empire. There was an evolution of a constitutional monarchy, a late migration after World War II, which constituted an assault on British identity. And then there was a need to establish minorities being different from the native-born British population. At the same time, a confidence and accurate diagnosis of schizophrenia, and the use of the present state examination and related instruments that may contribute to higher rates of psychosis when used systematically. No, they do use them. Yeah, there was a recent study that just came out this year, I didn't put it up here, that looked at the category mixed and found high rates of psychosis in the United Kingdom from the University of East Anglia. I could have sent that to you or given that to you here, but I just didn't put it in. There's so much stuff I had to exclude. Yeah. So they actually used that category in this study, which is interesting. No, people have problems with all this stuff, but it's kind of to the side. Okay, there's kind of the juggernaut of mainstream psychiatry, and then there's other people that are trying to raise questions. Okay, sort of like me. I'm sort of on the side, you know. So and I mean, yeah, it's a very interesting question, and it goes back to an ancient dilemma of non-white people in European civilizations. So Barack Obama, I always use as the classic example. His mother is Irish, his father is from Kenya, but he's called African American. Okay, so this is something that permeates all these problems. I think is that mixed becomes, no one really knows what, but it probably is lumped in with other minority groups of color, as people might say. So it's a sensitive issue. But these are dilemmas that these immigrants and other minorities are facing every day. I'm not going to talk too much about social causation of psychosis, like why immigration or why discrimination or why these things may trigger psychosis in vulnerable individuals. But that is an interesting area. We just touched on it briefly. So it's a good question, though. If you want to have material about this, just email me. I'll send you all kinds of stuff. You probably have too much to read already, right? You don't want to open the floodgates of all this stuff. Now, so the UK is a high rates country. Okay, that's what I would say. The US is an equal rates country. So I'm going to just say what I mean by that. So are racial categories permitted in the US? Absolutely. Okay, the UK and the US, the Anglo-Americans are linked on this one. Here's an example of the 2000 census. Now, just of interest, Spanish, Hispanic, Latino is, as of 2000, is not considered a racial category, okay? And then these other groups are, okay? Some other race is an interesting category. and one or more of these may be marked. Okay. Now, what about the 2010? The U.S. has national census every 10 years. It's very interesting to go back since 1790, I think was the first one, and you see what the categories are. It's very, very interesting, very revealing. Okay, so this is the 2010. There were some changes, some simplifications. I'm just trying to remember where they are. I think Asian was expanded quite a bit, so you could check off each of these different Asian categories now. It's not just Asian American. So, equal rates of psychosis. This is from the epidemiologic catchment area study, a very important study in the United States, looking at rates of mental disorders in different ethnic and other communities by gender and socioeconomic status and so on. And what they found for schizophrenia was a difference, a higher rate among African Americans. But once they controlled for all kinds of different things, the finding fell out of significance. But what was not examined is the link between being African American and being poor or being disadvantaged or so on. So this always remains unexamined in the American context. So since the civil rights movement in the 60s, there's been, and since that US-UK diagnostic project, misdiagnosis in African Americans with psychosis has been the paramount concern. And this is from the American Psychiatric Association supplement on the diagnosis and treatment of schizophrenia. I'll just read it to you here. Compared with Caucasians, African Americans, especially men, are less likely to receive a diagnosis of a mood disorder and more likely to receive a diagnosis of schizophrenia. So it just cautions clinicians to be careful about their diagnostic approach. Okay? So that's what they're talking about. Immigrants to the United States with psychosis has not really been examined, as far as I can tell, anywhere. It should be. It really needs to be done. But African American is a category that's the historic African American, descendants of slaves. Okay, and there's been many, many, many immigrants from the Caribbean and Africa over the last 100 years, obviously. But these groups kind of get sucked into that other group. And there's not much room for that so far, but it may happen. This is just a quotation from Protest Psychosis, very interesting book by Jonathan Metzl, where he finds that because some African Americans in the 60s were diagnosed as psychotic simply because they decided to protest and to be activists, in the civil rights movement. So they began to accumulate in this hospital, Ionia in Michigan. Very interesting book if you want to read that. So basically, reported rates of psychosis, I mentioned before, it was high in African Americans prior to 1970, equal rates since 1970. Social etiologies in the United States have been neglected. For example, migrants have not been studied. Misdiagnosis and clinician bias explain differences. And there's a new term coming out in the newest literature called disparities of diagnosis. So there's disparities of treatment. Like we talked about some already, getting antipsychotics and older generation and so on. But now there's disparities of diagnosis where some groups may receive higher rates of psychosis diagnoses. And the historical antecedents are similar, but there's a change around the 60s. So there's domestic slavery, segregation in the United States, a conservative revolution, and civil war. There were long-standing abuses of African Americans by medical research. Very interesting reading to go back and to list some, to find out what these are in the late 19th century and through the 20th century. A long history of this. Civil rights movement with a response of collective guilt by the American society. Sort of a need for equality among the races. A loss of confidence due to overdiagnosis of schizophrenia. We talked about the comparison with London in the late 60s, early 70s. And then a sort of a response of the diagnostic interview schedule, which is a very strict conservative diagnostic tool, which may flatten out differences, okay, by different groups, or may flatten a very conservative rating. Okay. So we're racing along. We don't have too much time, as I keep saying. So the third country is France. Is there any question about that? I'm sorry. Am I jumping over things? Or is it clear enough or murky? I hope it's not I hope it's too simple. So you can take it and then kind of think about it, I don't want to get it all muddled with things. So France, is a no-rates country, and I'll explain why, okay? Some of you may know this already. Basically, ethnic categories are not permitted in France. These are the categories that you can use. Citizen of the Republic, foreigner, okay? And there may be other categories, but it's very heavily controlled by the French government. It is, yeah, very heavily. Your funding can be pulled if you run awry of the government body that oversees this particular area of research. And we have colleagues in France who have been trying for at least 2 or 3 years now to come up with a similar intake form for our clinics, but it's very difficult for them because we're just so out there. You know, we have religious categories, we have ethnic categories, we have country of origin, just stuff that they just don't see as being possible. There's something called the Republican ideal. France came out of a revolution, you know, at the end of the 1700s. And there was this ideal that everybody was equal after that, before the law, before the government. All people were citizens and they should all just be seen as the same in many ways. Now, individually, obviously, that isn't the case, but in the eyes of the government was supposed to be, how do you call it? It was supposed to be a benefactor of the public, and wasn't supposed to address these kinds of differences, because if you address differences like that, there's room for abuse. That's the idea you're saying. And we'll talk about it a little bit, but this was abused during the Nazi times in Europe, especially in France. A great shame for the French nation. We'll talk about, I think I talk about it. Okay, Republican convictions. So this is debated in French society. How far should we go in having ethnic statistics? So by voting for this law, which forbids the wearing of ostentatious religious signs at school, we will follow the courageous precedent of our ancestors. So wearing external religious paraphernalia or clothing or symbols is forbidden. So by voting for this law, we will follow the courageous precedent of our ancestors who carried out their Republican convictions without pusillanimity. We will be faithful to our tradition, which came about during the Revolution. We will give new life to an essential Republican principle, secularism. We will make France shine in the world amongst those who crave light and who each day fight courageously against obscurantism. So this is the kinds of rhetoric. This is translated from the French. Okay, so it's better in French than in English. Maybe I should just have kept it in French. It would have been better. The dangers of ethnic statistics. This was sort of an item or something on the internet that you could sign and fill out. Okay, sort of as if to oppose the institution of ethnic statistics in France. I refuse ethnic statistics. I refuse to be asked about the color of my skin, my origin, or my religion. I refuse to have my identity reduced to criteria from bygone eras like the French colonial period or Vichy. I refuse that the attention and investigation be focused on the victims rather than the perpetrators of discrimination. The required knowledge of the reality of discrimination should be gathered by other means, for example, through individual in situ investigations of racist conduct. Okay, so it's an idealistic perspective, really, and when French colleagues see what's going on in North America or in the UK, they're, whoa, you know, where do you come by these categories, you know, like, how do you call somebody Arab or black or Asian? It's a valid question, really, because how do we know to assign them? I guess in the census people check it off themselves, but how do they come to this identity, right? And this is SOS Racisme, Petition Against Ethnic Statistics. Interesting, huh? Eradication of ethno-racial categories. I'm seeing if they talk about Vichy here. I don't think they do there. In the what? Before they talked about Vichy. Oh yeah, they mentioned Vichy. Basically what happened in Vichy France after Nazi Germany conquered the French Republic, Vichy France, the puppet was set up in the south of France, and they gathered statistics on people's religious identities, and the Jews were sent off for extermination. So since that time, you know, it's a terrible blight on the history of France, and They honestly, thinkers, researchers, people, many idealists just don't want that to happen again. So they want to forbid this kind of information from being gathered. So basically, officially, there are no ethno-racial categories in France, and thus no rates of psychosis by ethno-racial or migrant group. So just, again, there's the history. We've gone over the history already, really. Similarly to many other countries, there was late migration post-World War II, an assault on French identity, which is happening to this day. There are race riots in France, as we know, as in other countries. And there's a need to reaffirm, interesting twist, a need to reaffirm the ideals of the revolution, especially in light of what happened in World War II. So kind of a sympathetic response, really, in the idealistic sense. What's happening on the ground is quite different. And if you talk to French clinicians, they are well aware there are abuses and problems and ethno-racial tensions and so on. And there is some frustration not being able to document in a way that we would in North America or in the United Kingdom. There's no research on misdiagnosis, no systematic use of diagnostic instruments to collect ethnic statistics and so forth. So, psychosis in the African minorities of 3 countries. You can't really read this. I'm sorry, it's so tiny. So basically, are ethnic categories permitted? UK, yes. US, yes. France, no. Are migrants studied? Yes, no, no. High rates of psychosis reported? Yes in the UK, no in the US, no information in France. Misdiagnosis of psychosis reported. There's some discussion in the UK, but it's limited. In fact, there was a paper in 1997 by a prominent researcher in the UK who officially pronounced the end of the misdiagnosis problem. Okay? It's a very interesting article. You can read it from 1997, the British Journal of Psychiatry. I can send it to you if you want. But anyway, these are all just details. In the US, yes, misdiagnosis is, there was a recent paper just this year published again looking at research misdiagnoses in African Americans, white Americans with schizophrenia. So the same group is going on, and there tend to be research groups around these questions that are continuing. In France, there are case reports only of misdiagnosis. Social etiologies of psychosis reported. Yes in the UK, limited in the US, and no in France. Racism important. Yes in the UK. It's thought to be a cause of psychosis in new arrivals and immigrants to the UK. The US, clinician bias is what is in the literature. Not so much societal racism, but more individual bias in racial discrimination. And in France, there are case reports only. Again, you'll talk to clinicians and they'll have cases that they discuss, but there's no effort to systematically make comments. Global perception of minorities in the UK is different. In the US as different but equal. In the France as equal. Okay. As citizens of the Republic. And these are just a summary of the historical antecedents. So basically, these reported rates of psychosis vary markedly by country. Let's see, I think I've talked about all this stuff. Maybe multinational incident studies would be helpful, but everybody always suggests these mass. There actually is a multinational study underway now, looking at rates of psychosis in immigrants in Western Europe. There are 4 sites in Western Europe, the UK, Spain, France. I don't remember the 4th country. But it's underway now. It's been funded. One of our colleagues in London has gotten the permission to do that. So we'll see what that shows. It'll be interesting. I suspect I can predict the outcome, but we'll see. Maybe it'll be different than they think. And they have a site in France, and I'm not sure how they're gathering data there. I'm not sure what they're doing with that. So the final position on this example: rates of psychosis and schizophrenia are not universally the same, for a variety of reasons. Okay, any last final comments before I talk about a few clinical implications? I don't know if any of you are clinicians or not, but I can talk about a few ways this might come into play in the clinic. And the first 2 cases, these are extremely brief vignettes. The first 2 cases have to do with psychosis in immigrants to Canada. And the first case, a man came to Canada as a younger he was a young man when he had the first psychotic episode, but he was a child when he came to Canada. So he developed a fulminant psychosis, a fulminant suicidal psychosis, very severe. He nearly died. And it's an example of how psychosis may occur after migration. Of course, it doesn't mean anything with respect to rates, but when you're speaking to individuals on a clinical level, people may say on occasion that I was totally fine before I came to Canada. I came to Canada, and then everything fell apart, and I can't function, and I'm totally ill now. So that's anecdotally what people may say. The immigration, at least in the minds of people, is certainly a major change in their life. The second case is about a woman who also presented with psychosis, but after careful assessment and going back in time and talking to family members, it seemed that she had been psychotic for many years. So even many years before coming to Canada, and then we became aware of the psychosis in Canada. Okay, so could this be another way things are happening, that people with subtle vulnerabilities maybe migrating like everybody else, and then they get into a difficult situation and they can't function any longer the way that they did before, and so their psychosis is being counted finally, and then treated, and they get into this whole system of treating psychosis, So these are some of the dilemmas that we see. The next case, the third case, is about misdiagnosis. So we received a referral for an 18-year-old man from the Caribbean. And he had kind of an odd affect, we call it in psychiatry, how somebody kind of how their face looks. And his eyes were sort of, it's like he had nystagmus. He was kind of, couldn't keep a steady gaze on people. And he came across, I could see how he could come across a little bit shifty-eyed, or maybe blunted of affect, which means little expression in how he was presenting to us. And he was referred for an assessment of psychosis. But after talking to him, it became clear he was devastated. He was alone in Canada, a young man, no family support. He was very depressed and isolated. And so the blunted affect was more of a sad or depressed or withdrawn kind of a attitude that he had. And we wondered if it was a neurologic problem. We recommended that he get referred to neurology for assessment. So we felt it was a misdiagnosis of somebody. This can happen to any group, to any person, any time. I'm just raising some of the clinical links that may happen. The last has to do more with outcome and treatment. So a young man, again from the Caribbean, who went missing from his family. His family didn't know where he went, and he turned up in detention, in immigrant detention in Quebec. And so it was very touching. We reunited him with his family. They were very sad. They didn't know where he was. They were grateful to know that he was at least in a place, because they weren't sure what happened. He'd been it turns out that he was psychotic, had schizophrenia, very severe psychotic symptoms, untreated in this kind of forensic, or it's not really a prison, but it's kind of like prison, this detention center. And so we went and saw him, and he'd been kind of used by some other friends in a gang to sort of be present at a robbery of a store or something. And, because of that, he kind of got into the penal system, and he happened to be an Afro-Caribbean man. So I'm just using this as an example of what could be happening on the ground when there are findings from the UK or even from Canada or United States of a high rate of contact between police and people from certain ethno-racial or ethno-cultural communities. There's a sort of a culture of a material disadvantage, maybe lack of education or lack of understanding of how to work the system in Canada. And so you might get mired in these problems. And then he had no advocate to help him get proper treatment. So he only came to our attention because his lawyer recognized she couldn't communicate with him, So finally we were able to get him discharged from detention into a regular treatment facility. And we lost contact with him after that. I don't know what happened to him. But it was sad to see his parents, they were tearful, and they tried to give him clothes, and they were so concerned about him. So these are some of the clinical implications, or just clinical vignettes to illustrate some of the issues we've been discussing. The global implications are maybe simpler to state. Basically, in the world of psychiatric research and practice, there are many cultures. culture of French psychiatry, Canadian, UK, and so on, and of course many subcultures within those countries, especially the United States, where there's such a vast diversity already. Attributed etiology of psychosis and the reported treatment and rates of psychosis in ethnic populations are not universally similar, but vary according to setting. And these findings should not be surprising, given differences in the culture and history of psychiatry in different parts of the world. Okay, so that's sort of the presentation.